Last time we were discussing about the discussion of question number it's question number 56. So I'm sorry for the abrupt closure of the video. So now let's continue. So the patient presents with extensive smoking history and evidence of COPD and digital clubbing on the physical examination. Though he associates his wrist pain with a data entry job, it may be a sign of underlying lung disease. Hypertrophic osteoarthropathy is a condition where digital clubbing is accompanied by sudden onset arthropathy, commonly affecting the wrist and hand joints. Hypertrophic pulmonary osteoarthropathy is a subset of HOA, that is hypertrophic osteoarthropathy, where the clubbing and arthropathy are attributable to underlying lung disease like lung cancer, TB, bronchiectasis, or emphysema. Given this patient's smoking history, lung cancer should be a particular concern. Chest X-ray is an appropriate initial study for identifying the underlying cause of the suspected uh, hypertrophic, hypertrophic pulmonary osteoarthropathy. Moving on to the next point, next question. Next question, question number 57. In this question, they are asking about a 32 years old man with a known history of recreational substance abuse is brought to the emergency department. The patient was found by a friend on the floor of his apartment and with a pool of urine around him. He has been previously hospitalized for alcohol intoxication. The patient is confused, not oriented to time or place, and does not recall any recent events. The temperature is 37.3 degrees Celsius, that is 99.1 degree Fahrenheit. Blood pressure is 90 by 70 millimeter of mercury, and pulse is 67 per minute, and respirations are 12 per minute. He is drowsy and moves all his extremities. The pupils are small. Skin is mottled over upper back, buttocks, and posterior thighs. Cardiopulmonary examination is normal. The abdomen is soft and non-tender. The lab findings are as follows. Hemoglobin is 15.8 grams per deciliter. Platelet count is 160,000 per millimeter cube. Leukocyte count is high, that is 13,000 per millimeter cube. Serum chemistry shows sodium of 136, it is low normal. Potassium is very high, the potassium is high. Creatinine level is high, the calcium level is kinda low. Glucose level is 90 milligram per deciliter, it is also a bit low. Liver function test, albumin is 4 grams per deciliter. The total bilirubin is 1.1. Uh, bilirubin, okay. Bilirubin, I guess it is increased. Total bilirubin 1.1, okay. Then we have aspartate aminotransferase is very high. AST and ALT, both of them are high, are very high, and AST to ALT ratio is close to 2:1. Blood plasma and serum. Phosphorus inorganic is 5.5 milligram per deciliter. Urine toxicology is positive for opioids. Over the next 2 days, this patient is at greatest risk of which of the following? Option A, acute kidney injury; B, intracranial hemorrhage; C, necrotizing fasciitis; D, osmotic demyelination syndrome; or E, splenic infarction. And the answer of choice is option A, that is acute kidney injury. Educational objective of this question is stating that rhabdomyolysis can result from prolonged immobilization with ischemic compression of skeletal muscles, a scenario that may occur following the ingestion of CNS depressant, for example, opioid. Affected patients commonly develop acute kidney injury due to decreased renal perfusion and direct renal tubular toxicity of heme pigment, which is contained in the myoglobin protein released from the lysed skeletal muscle cells. Now, coming back to the discussion, they have given us a table that is about rhabdomyolysis, skeletal muscle lysis and necrosis due to etiology, crush injuries or prolonged immobilization, intense muscle activity, for example, seizures and exertion, and drug medication toxicity, for example, statins. The clinical features include muscle pain and weakness, dark urine, which includes myoglobinuria and pigmenturia, positive blood on urinalysis and no RBCs on microscopy, increased serum potassium and phosphorus, decreased serum calcium, and increased AST more than ALT. And then we have the acute kidney injury. The diagnosis, that is serum creatinine kinase more than 1000 units per liter, and consistent clinical feature will help you making the diagnosis. Then management, aggressive intravenous fluid resuscitation and sodium bicarbonate in some cases. Moving on, this patient who has a history of substance use, that is opioid and alcohol, was found down by a friend, has laboratory studies consistent with the rhabdomyolysis and is at greatest risk of developing the acute kidney injury, that is AKI. The rhabdomyolysis results from the large-scale skeletal muscle necrosis by a mechanism that includes crush injury, ischemic injury, overexertion, and direct myocyte toxicity. Opioids and other CNS depressants, for example, ethanol and benzodiazepines, can cause rhabdomyolysis by inducing impaired consciousness with prolonged immobilization and ischemic compression of dependent areas of the skeletal muscles, for example, mottled skin over the back, buttocks, and posterior thighs. Acute kidney injury in the rhabdomyolysis is predominantly results from decreased renal perfusion due to intravascular volume depletion from shifting of fluid into the damaged muscle tissue and direct renal tubular toxicity of heme pigment, which are contained in the myoglobin proteins released from the lysed muscle cells. An increase in the serum creatinine is often delayed from presentation but can be profound over the ensuing days. Other laboratory abnormalities indicative of the rhabdomyolysis, all of which are seen in this patient, include the hyperkalemia and hyperphosphatemia, which result from the release of electrolytes from the lysed muscle cells into the bloodstream, hypocalcemia, which is often present due to deposition of calcium in the damaged muscle tissue, moderate transaminase elevation, which characteristically show greater elevation in the AST than the ALT due to relatively higher level of AST in the skeletal muscle. Okay. Then we have option B, C and D. None of them were the option of choice. They were intracranial hemorrhage, the necrotizing fasciitis and osmotic demyelination syndrome. They are not the options of choice because patients with a chronic alcohol abuse are at increased risk of intracranial hemorrhage, subdural hematoma, necrotizing fasciitis and osmotic demyelination syndrome. However, acute kidney injury is more likely in this patient with a history of lab findings consistent with rhabdomyolysis. Osmotic demyelination syndrome, which results from the rapid concentration of hyponatremia, is particularly unlikely given that this patient's serum sodium is normal on presentation and will not require the correction. Option eta, that is splenic infarction. This is not likely to be happening in this patient because splenic infarction can occur due to embolic disease, for example, atrial fibrillation, infective endocarditis, or in the setting of myeloproliferative diseases like myelofibrosis. It is unlikely to occur in this patient with no cardiac murmurs or rhythm abnormalities on physical examination and no hematologic abnormalities other than mild leukocytosis. The next question is question number 58, and they are asking about a 45 years old woman comes to the emergency department due to 3 days of fever, malaise, and progressive dyspnea on exertion, dyspnea on exertion, dry cough, abdominal pain, and watery diarrhea. Her stools this morning were accompanied by bright red blood. The patient underwent allogenic rectal transplantation 6 months ago and is currently taking tacrolimus, mycophenolate, and prednisone. 2 months ago, she developed severe leukopenia, which resolved after discontinuing the trimethylene sulfamethoxazole and valganciclovir. She does not use tobacco, alcohol, or illicit drug. Temperature is high, that is 38.9 degrees Celsius. Blood pressure is 110 by 70 millimeters of mercury, and pulse is 114 per minute, and respirations are 22 per minute. Physical examination shows bilateral lung crackles, diffuse abdominal tenderness. Gross blood is seen in the rectal examination, and lab results are as follows. Hematocrit is 30%, kind of normal. Platelet count is 118,000. Leukocyte count is 3800 per milliliter. Serum chemistry is BUN of 24, that is high. Creatinine level is also high. Liver function study shows total bilirubin is high. Alkaline phosphatase and AST, both of them are high, and alanine, all three values of alkaline phosphatase, AST and ALT, all of them are high. Urinalysis is normal. Chest X-ray reveals bilateral interstitial infiltrates. Which of the following is most likely cause of the patient's current condition? Options are Aspergillus fumigatus, Candida albicans, Cryptosporidium, cytomegalovirus, influenza, Legionella pneumophila, mycoplasma pneumonia, or pneumocystis jirovecii, and the answer of choice is option delta, that is cytomegalovirus. Educational objective of this question states that patients who receive solid organ transplant are at risk of opportunistic infection, most notably pneumocystis pneumonia and cytomegalovirus. In the absence of prophylaxis, patients who present with a systemic illness involving multiple organ systems like pneumonitis or hepatitis and gastroenteritis should be tested for cytomegalovirus. Then we have patient receiving the solid organ transplantation. Patients who are receiving a solid organ transplantation require high dose immunosuppressive medications to prevent the organ rejection. This results in the systemic immunosuppression, which puts them at risk of opportunistic infection, most notably pneumocystis pneumonia and cytomegalovirus. The patient was on prophylaxis for PCP, that is trimethoprim sulfamethoxazole, and cytomegalovirus, that is valganciclovir, but both medications were discontinued 2 months ago due to leukopenia. She now presents with pulmonary symptoms, for example, dyspnea on exertion and dry cough, gastrointestinal symptoms like abdominal pain, diarrhea, and hematochezia, pancytopenia, mild hepatitis, and interstitial infiltrates on chest X-ray. The combination of findings strongly suggests tissue-invasive cytomegalovirus disease causing pneumonitis, gastroenteritis, and hepatitis. Viremia can be detected in the blood using polymerase chain reaction, but may not always be present. Tissue biopsy is the gold standard. Treatment involves discontinuing uh, treatment involves discontinuing anti-metabolite immunosuppression, for example, mycophenolate, and initiating the antiviral therapy. Intravenous ganciclovir is used for the patient with severe disease, for example, pneumonitis, meningoencephalitis, high viral load, significant gastrointestinal disease. The patient with the minimal signs and symptoms can take oral ganciclovir as well. The choice alpha, that was Aspergillus fumigatus. It was not the option of choice because aspergillosis primarily causes pulmonary disease, fever, pleuritic chest pain, and hemoptysis, although it may involve other organs. Aspergillosis tends to cause nodules and focal infiltrate in the chest, external bilateral interstitial infiltrates, and gastrointestinal disease is uncommon. The choice beta, that is Candida albicans, this is not the option of choice because Candida colonizes airway and usually does not cause pneumonia. The gastrointestinal disease is also uncommon. The choice Charlie, that is Cryptosporidium. This is not the option of choice because the Cryptosporidium causes diarrhea in the immunosuppressed patient but usually does not involve the lung. Option Eta, that is influenza. This is not the option of choice because influenza typically causes high fever, headache, malaise, and sore throat. Pneumonia is a common complication. Gastrointestinal disease, colitis, pancytopenia, and hepatitis are uncommon. The choice F, that is Legionella pneumophila. This is not the option of choice because Legionella often presents with a high fever, that is more than 39 degrees Celsius, 102.2 degrees Fahrenheit. Gastrointestinal symptoms like diarrhea and pulmonary symptoms. However, the bloody diarrhea is an unusual manifestation of legionellosis. Legionellosis and cytomegalovirus is a far more prevalent infection. If the cytomegalovirus DNA PCR is negative, other less common causes like Legionella can be explored. The choice G, that is Mycoplasma pneumonia, this is not the option of choice because Mycoplasma causes headache, fever, sore throat, and cough. It typically does not cause gastrointestinal symptoms. And the choice H, that is Pneumocystis pneumonia, this is not the option of choice because Pneumocystis cerevisiae, I'm sorry. Yeah, but that causes Pneumocystis pneumonia. So Pneumocystis pneumonia is a common infection in the solid organ transplant patients who do not receive prophylaxis. The PCP present with the pulmonary symptoms, respiratory failure, cough, and dyspnea, but typically does not cause gastrointestinal or hepatic issues. The next question is question number 59, that is about a 64-year-old man with a history of hypertension and diet-controlled diabetes mellitus type 2 comes to the office due to generalized malaise and palpitation for the past 2 weeks. An echocardiogram last year showed mild left atrial dilation and left ventricular hypertrophy. Okay, the patient's medication include lisinopril and hydrochlorothiazide. The blood pressure is 170 by 90 millimeters of mercury. The ECG is shown in the exhibit and we don't have the exhibit, so we have to make a wild guess. Which of the following is the most appropriate next step in the management of the patient? And the options are adenosine, electric cardioversion, the carotid sinus massage, deltaism or lidocaine, and the answer is option delta, that is deltaism. So I wish we had a picture of the ECG, but since we don't have it, so let's continue with the educational objective. In atrial fibrillation, so if it is atrial fibrillation, so there will be a lot of QRS waves without uh, P waves in the middle. So atrial fibrillation with a rapid ventricular response, rate control should be attempted initially with a beta blockers or calcium channel blockers. Immediate synchronized electrical cardioversion is indicated in hemodynamically unstable patient with a rapid atrial fibrillation. The discussion is stating that the patient's ECG findings of the irregular rhythm with narrow complex tachycardia and no organized P waves are consistent with the atrial fibrillation with a rapid ventricular response. Atrial fibrillation is a supraventricular tachyarrhythmia with unorganized atrial activity. Atrial fibrillation with a rapid ventricular response can present with a ventricular rates as high as 150 per minute, and the symptoms are usually due to the fast ventricular rate rather than the arrhythmia itself. Management of new onset atrial fibrillation includes assessing for the rate versus rhythm control, strategy in preventing systemic embolization. Hemodynamically unstable patients, for example hypotensive, require emergency cardioversion. Stable patients can receive medical therapy, for example beta blockers, deltaism, to control the ventricular rate. Rhythm control for maintaining the sinus rhythm should be considered in the patients unable to achieve adequate heart rate control or in those with recurrent symptomatic episodes, for example palpitation, lightheadedness, dyspnea and angina, or heart failure symptoms in the setting of underlying left ventricular systolic dysfunction. Regardless of whether the rate control or rhythm control is used to treat the atrial fibrillation, all the patients should undergo a CHA2 DS2 VASC score assessment to estimate the thromboembolic risk. Okay, so it is basically CHAD score or VASC score. CHAD score or CHAD VASC score. Basically, these are the scores which we use for the thromboembolic risk. The patient score is 2. 1 point for hypertension, 1 point for diabetes mellitus, and 0 points for age as it is less than 65. As he should be started on oral anticoagulation with warfarin or other anticoagulants, for example, dabigatran, rivaroxaban, apixaban, to reduce the risk of systemic thromboembolism. Option A and C, that are adenosine and carotid sinus massage, these are not the options of choice because the paroxysmal supraventricular tachycardia usually presents as a sudden onset regular narrow complex tachycardia. Okay, so it's sudden onset regular and narrow complex tachycardia. Adenosine shows atrioventricular nodal conduction to interrupt the re-entry pathway and terminate the PSVT. The carotid sinus massage is a vagal maneuver that can also terminate the paroxysmal supraventricular tachycardia by transiently slowing the sinoatrial nodal activity and the atrioventricular node. Okay, so adenosine and carotid sinus massage can cause transient atrioventricular block and slow the ventricular rates in the atrial fibrillation, but are not effective for the long-term rate control. The choice beta, that is electrical cardioversion. This was not the option of choice here because urgent electrical cardioversion is indicated in the patient with a hemodynamic instability and evidence of myocardial ischemia, new onset chest discomfort, or significant heart failure, that is pulmonary edema is there. It is not indicated in stable patients in whom adequate heart rate control can be achieved with medical therapy. Moreover, attempting cardioversion in the patient with atrial fibrillation for an unknown duration or more than 48 hours without adequate anticoagulation increase the risk of systemic thromboembolism. The choice eta, that is lidocaine, it is not the option of choice in this patient because lidocaine is an lidocaine is an antiarrhythmic drug used primarily for testing ventricular arrhythmias. It is not effective in therapy of atrial fibrillation. Moving on to the next question, that is question number 60. So in this question they are asking about a 44 years old woman comes to the office due to excessive thirst and urination. She has to get up several times during the night to urinate. 2 months ago, she was diagnosed with type 2 diabetes mellitus. Which she manages with diet and exercise. The blood pressure is 134 by 78 millimeter of mercury. Pulse is 88 per minute and BMI is 32 kg per meter square. The remainder of the physical examination is normal. Laboratory results are as follows. Sodium is high, 147 millicavalents per liter. The potassium is low, it's low, 4 millicavalents per liter. Then we have chloride, that is 106 millicavalents per liter. Bicarbonate is 26. Okay, there's a lot of derangement and I'm not sure if it is deranged or not, but okay, it's chloride and then we have bicarbonate. Then BUN is 26. Okay, glucose is 112 and creatinine level is a bit high and calcium level is 928 and serum osmolality is high. Okay, this is definitely high. Serum osmolality is 305 milliosmol per kg and urine osmolality is low, that is 180 milliosmol per kg of water. Urine specific gravity is also low, that is 1.001. Which of the following is the most likely cause of the patient's excessive thirst and urination? Diabetes insipidus, excessive antidiuretic hormone production, hyperglycemia, hypothyroidism, or impaired thirst perception. And the answer of choice is option A, that is diabetes insipidus. Educational objective of this question states that urine osmolality and specific gravity can be used to narrow the cause of suspected polyuria. Low urine osmolality, low urine specific gravity, that is less than 1.006, suggests dilute urine as seen in the diabetes insipidus. High urine osmolality and high urine specific gravity suggest the osmotic diuresis from the conditions such as diabetes mellitus. Then we have this table, causes of polyuria and dilute urine: primary polydipsia, central diabetes insipidus, and nephrogenic diabetes insipidus. So let's talk about primary polydipsia first. The cause of primary polydipsia is ADH independent excessive water intake. Etiology is antipsychotics, dry mouth. Antipsychotics cause a dry mouth in psychiatric conditions. Then result of water deprivation will cause urine osmolality to go high. Like if we do the water deprivation test, the urine osmolality will become normal or will become high. And then we have response to desmopressin, there will be no change because the ADH is already doing its job. And then we have central diabetes insipidus. The cause of central diabetes insipidus is ADH deficiency, and there is a CNS pathology. Then etiology is idiopathic, trauma, pituitary surgery, and ischemic encephalopathy. Results of water deprivation will result in low urine osmolality. The urine osmolality will not increase in response to water deprivation because the problem is with excessive the problem is with lack of production of ADH. Then we have response to desmopressin. So in response to desmopressin, In response to desmopressin, there will be increased urine there will be increased urine osmolality, and then we have the peripheral, or not peripheral. There is nephrogenic diabetes insipidus. Causes are ADH resistance, that is the renal disease. The etiology is chronic lithium use, hypercalcemia, hereditary AVPR2 and ACOPRN2 mutations. Then we have the results of water deprivation. Low urine osmolality will if we cause the water deprivation test, there will be low urine osmolality. Response to desmopressin is that there will be no change. Now moving to the next point, this patient with a high serum osmolality and urine studies show low osmolality and specific gravity likely has diabetes insipidus. So the patients with high serum osmolality and urine studies showing low osmolality and specific gravity likely has diabetes insipidus. Diabetes insipidus can be caused by either deficient antidiuretic hormone production, that is central diabetes insipidus, or renal ADH resistance, that is nephrogenic diabetes insipidus. Both central and nephrogenic diabetes insipidus are characterized by impaired water reabsorption and concentration of urine, resulting in high serum osmolality, polyuria and dilute urine. In this patient, polyuria, for example, more than 3 liters of urine per 24 hours is suggested by frequent urination and nocturia. Mild hypernatremia is present. This common finding in diabetes insipidus reflects ongoing water losses and maintains a stimulus for compensatory polydipsia in the patient with the intact thirst reflex. Low urine osmolality is less than 300 milliosmol per kg of water, and low urine specific gravity, that is less than 1.006 in the setting of high urine osmolality, more than 250 milliosmol per kg of water, reflects the inappropriately dilute urine. The polyuria with a high serum osmolality can also be seen in the diabetes mellitus, complicated by marked hyperglycemia, for example diabetic ketoacidosis. However, diabetes mellitus causes osmotic diuresis, for example glucosuria, which with a high urinary solute concentration. Therefore, urine specific gravity and urine osmolality, for example typically more than 600 milliosmol per kg of water, are high in diabetes mellitus. So in our patient it is low. This patient's low urine osmolality, low specific gravity and only mild elevated glucose level makes diabetes insipidus a much more likely cause of urinary symptoms. The choice beta, that is excess antidiuretic hormone production. This is not the option of choice because the syndrome of inappropriate ADH production is characterized by excessive ADH production. It is characterized by excessive ADH production. This causes concentrated urine. Polyuria is not seen and the patients typically have hyponatremia. The choice delta, that is hypothyroidism. This is not the option of choice because hypothyroidism can cause hypotonic hyponatremia resulting from decreased free water excretion. It is not associated with a hypernatremia and persistently dilute urine seen in this patient. The choice eta, that is over here, the choice eta, that is impaired thirst perception. This is not the option of choice because impaired thirst perception can cause primary polydipsia, seen in the psychiatric condition or CNS lesions, resulting in the excessive water intake and dilute urine. However, patients have low serum osmolality and sodium, that is hyponatremia. This patient is hyperosmolality and hypernatremia with dilute urine. Therefore, her polydipsia reflects an appropriate thirst reflex for replacing the ongoing water losses. So we'll keep this session till here and we'll continue with the question number 61 in the next session. Until then, Allah Hafiz, fi amanillah, and take care.